Good evening, welcome to Taking Stock. I'm Bruce Whitfield and you're on ENCA, the home edition of Taking Stock, looking beyond COVID-19. Well, South Africa in a surge in terms of COVID-19 infections. We're seeing a big increase in Gauteng, Eastern Cape, KwaZulu-Natal in particular, as the Western Cape shows signs of perhaps being over the worst. Tonight, three doctors on the program. We'll talk to Dr. Ryan Noach at Discovery, Dr. Richard Frieldland at Netcare, and also to Dr. Jonathan Louw at the South African National Blood Service, as we try to make sense of the latest when it comes to COVID-19. Well, first up this evening on Taking Stock is Dr. Jonathan Louw. Jonathan Louw is the Chief Executive of the South African National Blood Service. Blood Service, of course, always has problems with supply and stock levels, especially in busy seasons, Easter, Christmas, for example, when we tend to do ourselves a lot of harm while we're on holiday. During this period of COVID-19, however, it's hit a couple of new stumbling blocks. People are less keen to go out and lie in public to go and donate blood. And also, there's been a huge demand for blood during this time. Jonathan Louw, what is the state of play when it comes to South Africa's blood supplies?
So, Bruce, thank you for having me on your show today. Certainly, it's been a tough time for the blood service, as much as it's been a tough time, I think, for any of the folk in healthcare, particularly the frontline workers. So, from our perspective, not only have we had our own people, in some cases, infected with COVID, having to be in quarantine, so it's difficult to collect blood, but the cold weather at the moment, and of course, the difficulty in the closure of all public spaces. So we used to go to churches, we used to go to schools, we used to go to community gatherings to gather blood. Naturally, that's been pretty difficult. This, of course, is also coupled with, at some stages, a reduction in demand. So the hospitals, as we know, were closed for quite a period of time. They just weren't doing elective procedures. So because of this, demand reduced, and at one stage early in the disease, we had an overstock situation. But right now, I think it's quite the opposite. Our stock cover's down to about 3 days. So we really are urging donors out there, particularly O-negative people that can donate emergency blood, please come forward and assist, save some lives.
I mean, there's also been an appeal for blood plasma. Now, blood plasma is seen as being very helpful to COVID patients, particularly in the early stages of infection. It can help, as I understand it, and I've got to be careful because everyone's become a scientist in the last couple of months, but it can help COVID patients speed up their recovery in less serious cases.
Yes, so convalescent plasma was used quite effectively in SARS and MERS, the two previous coronaviruses that came about. And also there's been a lot of anecdotal evidence from the use in Ebola. So this causes or gives what is known as passive immunity. So if you're in the early stages of the disease, you use somebody else's antibodies, and that's able to buy you time so that your own antibodies can switch on and really stop you progressing to a much worse form of the disease. What we need to state, I think, categorically is that it's still not adequately proven in terms of clinical trials. So we want to do the right thing. We've commissioned a trial on the collection side. We have about 57 donors that have come forward and have useful antibodies. And then we're now in the second part of the trial where we're starting to give those antibodies imminently. And that'll be done with UCT's HREC, their Human Research Ethics Council, as well as the South African Health Products Regulatory Authority. So we're waiting for SAHPRA to give us the final approval and the go-ahead for that trial. But we shouldn't just willy-nilly use this particular product. It needs to be done in a controlled fashion. We need to prove that it works.
You're one of those donors. You're one of the early victims, if you like, of COVID-19. You'd been traveling internationally and you become infected. You came home and you were sick for a long time. Just take me through it, if you would, that experience as a medical professional, as somebody who is asthmatic, as somebody who knows intellectually what is happening to their body. It must be awful.
Yeah, it was I won't say an interesting time. In some ways, I seem to be, whether it's drones or whatever, I seem to be on the cutting edge of innovation and getting things. So in one way, it was a boon that I was one of the first people in South Africa to be infected with COVID-19, because that put the blood service I think, right in sort of on the front foot when it came to this. So when one of your own becomes infected, you put in place protocols and all that kind of stuff very quickly. The experience itself was frankly horrible. So I wouldn't wish it on my worst enemy. I came back from overseas. I was perfectly well. We'd heard that the area that I'd been in, there'd been a cluster of COVID infections. So I decided to go for a test. I self-isolated regardless, so I just didn't go into work. Phoned the board and said, look, been in this area, probably been overcautious, but let me just stay away from you guys. And during the board meeting, my test came back, and it came back positive. At the same time, my symptoms started. So I started getting really hot and sweaty and feeling a bit dizzy. And I thought that there was a peculiar smell in the car because it was load shedding. I had to go and park in a parking lot somewhere and do the call from inside my car because I wanted to stay socially isolated. And it was like somebody had spilled oil or something in the vehicle. I kept looking for this. And that's one of the early signs, actually, of COVID, is weird smells and losing your sense of smell. And frankly, after that, it was pretty much downhill. Went to my chest, lots of nebulizers. I had everybody phoning me and saying, look, you can use hydroxychloroquine. Don't worry, the BCG is protective. You know, you're in the southern hemisphere. It's warmer. You're going to be fine. I mean, it was just amazing how much data was coming out maybe too soon.
How much of what has happened in the last 3 or 4 months, the crackpot science, or is it crackpot science, or is it simply science eliminating possibilities as you go along, as you're going through something which nobody's had before, so therefore you become an early stage guinea pig almost?
Yeah, so I think with social media and with just the information age, information's probably coming to the general public in some senses too quickly and understilled. So epidemiologists will connect the dots and say, because there's less deaths in the southern hemisphere, and those people have mostly had a BCG vaccination, therefore the BCG protects against coronavirus, which we've subsequently shown just isn't true. So I think there hasn't been adequate dialogue and distilling of the data to be able to make hard, fast calls when it comes to clinical protocols. At the moment, obviously, dexamethasone is the one that's purportedly the wonder cure. But to be frank, in any overwhelming viral infection, you'd use injectable steroids. So I don't know necessarily if it is the silver bullet that we're looking for.
When you look at the environment in which we're seeing a terrifying escalation in the Eastern Cape and in Gauteng in particular. There are lots of hypotheses, lots of people modeling outcomes, lots of calculated and scientific guesswork going on. Where are we in the cycle as you see it?
What I'm really worried about is that if we look cumulatively, we're in the top 10 in the world when it comes to cases per million. But even more concerning is if one looks at the daily case rate, we're number 1 in the world. So this thing is spreading like wildfire. We're ahead of Brazil, we're ahead of the USA. Now is the time to really social distance, to wear the PPE, to stay at home, to be safe. And if you have any symptoms, to make sure that you seek medical attention as quickly as possible. This thing really is burning like wildfire through Gauteng and the Eastern Cape. The Western Cape appears to have some flattening of the curve, but most epidemiologists are telling us that the curve is going to be longer than they anticipated. So I think Gauteng's probably in for the peak somewhere around September. We really are. This is where COVID-19 really hits home, is right now.
The virus itself, of course, taking hold very, very significantly. In a moment, the chief executive of Netcare, Dr. Richard Frieldland, as hospitals start to stretch at the edges. We'll find out about capacity. We'll find out about how they are coping in a world of COVID. On now to Dr. Richard Frieldland, who's Chief Executive of the private hospital group Netcare. Richard Frieldland, how is the Netcare network holding up? Huge pressure, no doubt, in Gauteng, huge pressure in the Eastern Cape.
Yes, indeed, Bruce. We have seen a lot of pressure in the Eastern Cape, and we are seeing a surge now in Gauteng and also in KwaZulu-Natal. But the epicenter has moved from the Western Cape to Johannesburg in particular, and to the Gauteng, with well over 100,000 cases now being recorded.
In terms of what you see in patterns, in terms of admissions, in terms of infections, how best do you ascribe the surge? I mean, what is happening on the ground that is leading to this dramatic growth that we see?
Well, I think the real reason we're seeing the surge in the Gauteng is because of population density. And in fact, Gauteng dwarfs the rest of the provinces by an order of magnitude. That's number one. We've got the coldest winter in July since 2011. And I think those are all contributing factors. And of course, we don't have lockdown. In terms of what we see from a hospital perspective, approximately 15 to 20% of people who contract the virus will require some form of hospitalization. And that's usually delayed by 7 days. So whatever the number was yesterday, take that forward. So 10,000 cases yesterday, you're going to see 2,000 people requiring hospitalization in South Africa. And about 30% of those will require some form of critical care. So you're looking at 600 people will be requiring some form of a critical care bed in the next 7 to 10 days. Critical care is delayed by 10 days, hospitalization by 7. So these are the lead indicators, and that's what we see. So every time there is a surge in numbers, and we're seeing that, it has a direct correlation on the need for hospitalization. Of course, 80 to 85% of people will have either an asymptomatic or mild condition, and so they won't require, mercifully, any hospitalization.
How are the hospitals holding up?
Well, Bruce, we've spent the last few months preparing. It's somewhat like preparing for a comrades marathon. And you have a lot of injuries, you have a lot of setbacks, but you've got to get to the start. And we're now in that race, and it's going to be a long haul. Make no mistake about it. And it's not how you start, it's how we're going to get through this. And so we've been bolstering oxygen supplies, measuring that very carefully, PPE, ensuring we've got enough staff, arranging people into teams, making sure we've got enough drugs. There are 5 or 6 key rate limiting factors you've got to get right. And then obviously the last one is cash flow. You've got to be able to pay for all of this at the end of the day.
In terms of hospital admissions and in terms of pressure on the network, we saw the lockdowns. They came really early, and the transmission was contained. We had a lovely flatlining, which is then escalated very dramatically as we've opened up the economy, as we've been forced to do because of the long-term consequences, economic and health-wise, of keeping the lockdowns in place. Did we have enough time, and did we do enough in that first phase, the 100 days, if you like, of the lockdowns to prepare for what may come?
Bruce, I certainly can't speak for other groups, although I do believe that we're in a similar position. And I think certainly in the private sector, we did everything possible. And I certainly think government did a lot to try get ready for this. I do think the numbers in Gauteng are going to be very, very significant. If you look at the Western Cape, you know, their population is way less than the Gauteng, and they're over that surge, and it almost looks like Table Mountain. They've kind of reached the peak, they're plateauing, and it's coming off very nicely. Gauteng is very, very different, and I think we're going to see a lot of pressure on beds. And mercifully, we've come late into the pandemic, and so we've learned very hard lessons from the Chinese, the Italians, the French, the Spanish. You don't have to ventilate everyone. In fact, maybe that's not the best treatment. We now know that there are different forms of oxygen therapy that you can give patients in a general ward that are equally effective. Also, we now know that cortisone works very, very well. And that can reduce ventilator deaths or deaths due to ventilators or patients on oxygen. And we also know that there are lots of clotting abnormalities. So we're using anticoagulants. And all of this is helping reduce the mortality rate and also reduce the length of stay. You know, our average length of stay is now only 9 to 10 days. At the beginning of the pandemic, when we modeled this, the lengths of stay in Europe and in China were close to 18 days. So I think what you're hearing is that we're getting better at treating this. It is a killer, make no mistake about it. It's a ghastly disease. We've got to retain our humanity through this, but we are getting better at treatment modalities.
And also, you've learned some very painful lessons too. I mean, at the start of this pandemic, of course, St. Augustine's and another hospital in Durban had to be shut down to be cleaned out because Patients were being admitted with absolutely no symptoms whatsoever, with other ailments, and suddenly there were these huge spreads of this virus throughout the corridors of, say, St. Augustine's, for example. How have you managed to avoid repeats of that crisis?
Well, I think we knew so little in March, and so did the world. You know, no one knew in March that you should be wearing a mask. We now know today, Bruce, that wearing a mask is singularly the single most important aspect of preventing transmission. It's more important than washing hands. I'm not saying that isn't, but we now know that. We didn't know that when we had our first case on the 9th of March. And the first case that we had also had neurological problems, both at Kingsway and St. Augustine's. We never associated that with COVID. Now we know strokes and heart attacks are common because of the clotting abnormalities in COVID. So we've learned an enormous amount. And, you know, we were the first in South Africa to introduce masks on the 23rd of March. The World Health Organization was still saying on the 24th of April, there's no evidence to suggest that these are helpful. Now we know different. And so I think what we're saying is the textbook hasn't been written, and we've learned some very painful lessons, and we mourn the loss of any and every single individual who has passed away as a result of COVID in our country. And unfortunately, we are seeing a number of people passing away as a result of it.
Dr. Richard Frieldland, Chief Executive of Netcare, joining us on Taking Stock this evening. Thank you very much. In a moment, Dr. Ryan Noach, who is at Discovery. Pick up with him in a moment. Well, what is this crisis costing? Certainly the health budget is going to get blown this year in an environment where money is very, very tight indeed. In the private sector, the biggest medical aid in the country is Discovery. From Discovery, Dr. Ryan Noach joined us. Have you got any perspective, Ryan, as to what this thing costs by the time it is done?
It's expensive, Bruce, and you know, we weren't expecting any of these costs when we priced the scheme budgets, you know, towards the latter half of 2019. It's a new disease and new cost. A lot of people are saying to us, most of the typical hospital admissions, elective surgical procedures and the like aren't happening now. You guys must be saving a lot of money. And so the truth is claims are much lower at the moment, but our forecasts show that the catch-up from COVID over a 2-year period by the end of 2021 will cost the industry about 7 to 30 billion rand. Sorry for the wide range, but one's never sure exactly of where this epidemic goes. 7 to 30 billion rand at an industry level, more than was anticipated.
And so this is medical schemes. It's not a cost to the industry, it's cost to medical schemes, and members of medical schemes therefore have to either absorb that cost or have to contribute higher rates in future. So the cost of COVID-19 to individuals with medical aids therefore increases 2021 and beyond.
Potentially, Bruce. We hope not to. At Discovery, we consider it our social mandate to try and keep healthcare affordable. As you understand, medical schemes are mutual funds. They trust funds that hold members' money in trust, and what they receive from members they use to pay the claims. And really success for us is a zero surplus or deficit at the end of a period, which is pretty tough on a 80 billion rand income, but that would be success. And so looking forward at the contribution increases, obviously within this trust, the trust needs to be kept whole, and what comes in premiums must be there to pay for claims. We're doing everything in our power to optimize that and to ensure that consumers are protected to the greatest extent possible.
At this stage, as we sit in July into August 2020, relative to where we were this time last year, one would assume you've got a lower claims rate than you might have had 12 months ago. Your concern, however, is that as infections rise, particularly as Richard Frieldland's been explaining, KZN, Gauteng, the Eastern Cape may be plateauing, the Western Cape may be plateauing. But if we do see the surge continuing at the rate at which it is continuing before we get some kind of constraint, your concern is that the claims ratios start shooting through the roof.
Yeah, that's absolutely correct. If you look at the stages of lockdown and how that impacted our claims, During April, during the level 5 lockdown, typical hospital admissions were 50% lower than expected. Level 4 was 40% lower, and level 3 has been about 30% lower than expected. That does mean that there's a material surplus in the scheme now relative to what we thought or expected to pay hospitals and doctors at this time. We see that all being consumed by July next year based on the current COVID outbreak. I'm sure Richard alluded to it, but we have now one of the highest attack rates in the world. The attack rate is running at just over 30 new infections per 100,000 people per day, which is way higher than what Europe's highest attack rates were at the peak of the epidemic in Europe. And so we're effectively tracking on the highest trajectory of the modeled curves of this outbreak in South Africa. And so we potentially are facing a very tough time.
You're talking about the overall numbers. What about your member numbers? And then more specifically, what may be interesting here is the entire Discovery business model based on the fact that you encourage people to live healthier lives. You encourage people to subscribe to Vitality, which is the wellness program. How different are those attack rates, if you like, relative to the general population?
No, that's the question I was hoping you would ask. Let me just start with the Discovery member stats that you asked for first. As of this morning, we've had 32,000 Discovery Health administered members test positive for COVID-19. Of those, 5,700 have landed up in hospital. That's about an 18% hospital admission rate, which is slightly better than what the rest of the world reported. Between Italy and the US, where most of the data has been reported, they experienced a 20 to 25% admission rate. And the mortality rate so far in the Discovery membership base is a very sad 338 Discovery Health administered members that have died. It's tragic. Every one of those is a family badly impacted. But the good news about the case fatality rate is that it's 1.1% for the Discovery member base, actually heading downwards towards 1%. The Gauteng fatality rate is quite low relative to the rest of the country. And so, this is very favorable compared to the international experience where, for example, in the US today, they're reporting a 6% case fatality rate.
Is that, again, the discrepancy between public and private healthcare? Is it about better healthcare? Once you get sick, once you're admitted, and once you get treatment, is it about quality of treatment, or is there something else at play?
There's many factors, and it's impossible to attribute it to one factor. While the Discovery Health case fatality rate is 1.1%, the country's case fatality rate at the moment is 1.8%. It's also very low on international terms. One of the biggest factors is about the average population age. I think we all know now, listening to the media, that this is a disease that does affect the elderly disproportionately. And our data really does correspond completely with this. And so it's about average age. And so the younger average age of our population in South Africa is protective against some of the mortality.
And then when it comes to then, if you distill from your Discovery membership base and you look at active Vitality members, people who are on your gold or your diamond statuses, is there evidence there to show that the healthy lifestyle that you seek to reward, in fact, does mitigate against the worst outcome when it comes to COVID-19?
Absolutely fascinating data emerging on this from both our UK experience, where we have a large health insurer, and here in South Africa through Discovery Health, and demonstrating on a statistically significant basis through a resilience index that we've created that physical activity reduces your risk of hospital admission and probably also your risk of death, but certainly reduces risk of hospital admission. We have a measure called the Vitality Engagement Metric, which is effectively a vitality measure for how physically active you are. I think we are measuring physical activity in our member base all the time, all day, every day. And we are showing a highly correlated reduction in a number of people with the same risk, same age, same chronicity, same chronic diseases. If you're physically active, you've got a lower risk of being admitted to hospital.
Dr. Ryan Noach, thank you very much indeed. Dr. Ryan Noach is with Discovery Health. My thanks to tonight's guests, to Dr. Richard Frieldland, Dr. Ryan Noach, and to Dr. Jonathan Louw, joining us this evening on Taking Stock, bringing us up to speed with the latest developments when it comes to COVID-19, the impact on the health sector, and of course the impact on costs as well, as this pandemic looks to destabilize healthcare finances for some time to come. Thank you so much for watching. Good night.